Management of prostate cancer. In this slide presentation, I will go over some of the basics about prostate cancer and its management. I will focus on surgery as the treatment modality. However, I will also mention active surveillance as an option. You will likely have met or will soon meet with the radiation oncologist to discuss radiation therapy. I will likely review a lot of information that you already know, but I'm doing this to make sure that we are on the same page. If you wish, you may take notes during the presentation and jot down any questions that you have. I will be happy to answer all of your questions at the end of the presentation. As you know, the prostate sits deep in the pelvis behind the pubic bone. The role in life of the prostate is to provide secretions that are mixed with the sperm. The secretions aid with fertilization of the egg. It is entirely a reproductive organ, and after you have had your children, it does not serve a useful role. It is not required to achieve an erection or experience an orgasm. However, the nerves required to achieve an erection run right beside it and can sometimes be injured in the treatment of prostate cancer. A variety of problems can arise in the prostate. As you know, the prostate can enlarge and pinch off the passageway through which you pee. In this scenario, men often complain of a decreased stream and frequent voiding. Infections of the prostate are also common. Of course, prostate cancer can also develop. If the prostate cancer is near the backside of the prostate, and if it is large enough, we can often feel it by examining the prostate through the rectum. However, if the prostate cancer is microscopic, or if it is present in the anterior part of the prostate, we may be unable to feel it. As you know, when we make decisions about what to do with prostate cancer and recommend treatment, we take three factors about the cancer into consideration. The first is your clinical stage, the second is your Gleason score, and the third is your PSA level. I will go over all three of these to help you understand how we make these decisions. The clinical stage is based on what we feel on our finger exam. As you can see here, T1 and T2 are stages that are localized to the prostate. T1 means that there is nothing to feel on the finger exam. It can be further substage to T1A, T1B, and T1C, depending on how the cancer was diagnosed. If the cancer was diagnosed because of an elevated PSA, we call this a T1C. On the other hand, if the cancer was found incidentally due to another procedure such as the transurethral resection of the prostate, which is often done for an enlarged prostate, this is called a T1A or a T1B, depending on how much cancer was found. A T2 prostate cancer can be further staged into T2A, B, and C. This substaging is based on the size of the nodule that we can feel. In T2A, there is only a small nodule felt occupying less than a quarter of the prostate. In T2B, the nodule is larger than a quarter of the prostate, but less than half of the prostate. And in T2C, the nodule occupies more than one half of the prostate. Finally, when we call a cancer is stage T3 or higher, we mean that the cancer on the finger exam feels as if it has gone outside of the boundaries of the prostate. The second factor is the Gleason grading system. This is based on the appearance of the prostate cancer under the microscope. This determination is made by the pathologist, who is the doctor who looks at the needle samples when they are obtained and makes the diagnosis of cancer. The system is based on the pattern that the cancer makes under the microscope. Essentially, there are 5 patterns, as seen on this diagram, where they are arranged in order of increasing aggressiveness from 1 to 5, 1 being the least aggressive and 5 being the most aggressive pattern. To get a Gleason score, we take the 2 most common patterns seen on the biopsy and add them together. So, for example, if you have only Gleason pattern 3 on the biopsy, your Gleason score is 6 out of 10 because 3 plus 3 equals 6. If you have Gleason patterns 3 and 4, then your Gleason score will be 7 out of 10, as 3 plus 4 equals 7. The order of operations is important because although both 3 plus 4 and 4 plus 3 have Gleason 7 cancer, the patient with 4 plus 3 pattern has a more aggressive cancer because he has more of the aggressive pattern 4 on the biopsy. Now, to put things into perspective, today we almost never see patients with Gleason patterns 1 and 2 because these were usually diagnosed when we did a lot of transurethral resections, or otherwise known as scrapings of enlarged prostates. We don't do these much anymore because we have very good medical treatments for enlarged prostates. Also, this pattern is very difficult to diagnose on a needle biopsy. Therefore, in today's age, Gleason 6 prostate cancer is the lowest Gleason grade that we see. It accounts for about 50% of patients diagnosed with prostate cancer. Gleason score 7 prostate cancer, which is a combination of Gleason patterns 3 and 4, accounts for about 35 to 40% of cancers. This is an intermediate Gleason score. Finally, Gleason patterns 4 and 5 combine to give Gleason scores 8, 9, and 10. These represent very aggressive cancers, which account for about 10 to 15% of all patients diagnosed with prostate cancer. Finally, we looked at the PSA level. Essentially, a PSA less than 10 is in the low risk range. A PSA between 10 and 20 is in the intermediate risk range, and a PSA over 20 is in a high risk category. As you can see here, we can combine the Gleason score, clinical stage, and PSA level to give you an overall risk assessment. So, for example, with a PSA less than 10, a Gleason score of 6 or less, and a clinical stage of T2A, this puts you in a low risk category. However, having any Gleason 7 or having a PSA over 10 would put you in an intermediate risk category. Finally, having a Gleason score of 8 or higher, or a PSA greater than 20, or a clinical stage of T3 would put you in the high risk category. These categories are generalities, and obviously there are a lot of differences between individual patients within each category. When I will see you after this presentation, I will give you an individualized risk assessment based on your actual values. Now I will discuss the radical prostatectomy procedure as a treatment option. As you know, this is an operation that can be done through a variety of different incisions. It has been described through a perineal incision as well as a lower abdominal incision. More recently, a laparoscopic or robotic prostatectomy has also been described. This is usually done through 5 or 6 1-centimeter incisions in the lower abdomen. Regardless of the approach to get at the prostate, the procedure itself is very similar. Our aim is to remove the prostate and the seminal vesicles. We then suture the bladder to the rest of the passageway to reconstitute the continuity of the urinary tract. Sometimes, we also recommend the removal of lymph nodes, otherwise known as a lymph node dissection or lymphadenectomy. Lymph nodes, seen here in green, are little glands along the lymphatic system that drains tissue fluid back into the circulatory system. Lymph nodes are redundant, so their removal has no impact on normal bodily function. However, they are often one of the first places where prostate cancer can spread to. These lymph nodes are located along the veins that drain the pelvis. The removal of lymph nodes does add about 30 minutes to the procedure, and there are some added complications that can arise from lymph node dissection. These include the formation of a fluid collection known as a lymphocele and a slightly higher risk of developing a blood clot in the legs known as a DVT. Lymphadenectomy does not improve the odds of being cured with surgery, but it does provide us with added information about the stage of your cancer. Removal of the lymph nodes is only recommended if the chances of having lymph nodes spread are higher than about 3%. I will use a special prediction tool called a nomogram to determine what the chances of having lymph node involvement are in your case, and will make my recommendations when I speak to you. As you can see on this diagram, the nerves to erection, as pointed out by the red arrows, run right beside the prostate in the groove between the prostate and the rectum. During surgery, they need to be peeled off the prostate very carefully if we are to save them. This is what is called a nerve-sparing procedure. If we feel that the cancer has gone outside of the prostate or is very close to these nerves, we may elect to sacrifice the nerves in order to remove the cancer in its entirety. Sometimes, this assessment cannot be made until at the time of the procedure. Once the prostate is removed, the bladder is reattached to the passageway with sutures. In order to help this connection heal, we leave a catheter in place, and this usually stays in for about 2 weeks after the procedure. This catheter is attached to a bag which you can wear on your leg. Usually, you are admitted to the hospital on the day of the procedure. The procedure takes about 2 to 2.5 hours. You then recover in hospital for about 2 to 3 days. When you wake up, you will have a catheter in place. There will also be a drain in place, which will help drain any fluid from the operative site. The drain is also there in case there is any leakage of urine between the stitches. In general, this drain is removed before you leave the hospital. However, if there is persistent leakage of urine between the stitches, we may need to leave this drain in place until this dries up. You will have staples on the incision, and these will be removed generally about a week after the procedure in the hospital ambulatory care unit. You will then return 2 weeks later to have the catheter removed in my office. You are advised not to drive with the catheter in place. Recovery after the procedure in general takes about 6 to 8 weeks. However, this is very dependent on the person. Some people find that they are back to their desk job within 3 to 4 weeks, and others who have a more physical job can take longer than 8 weeks. No surgical procedure is without potential risks and complications, and this is no exception. There are anesthetic and medical complications that can occur after any surgery. These include things like heart attacks, strokes, blood clots forming in the legs and potentially launching into the lungs, pneumonia, and other anesthetic problems. Around the time of surgery, we do our best to minimize the risk of these complications by, for example, using stockings and blood thinners to prevent blood clots. There is always a risk of dying from surgery, and for this particular procedure, it is about 1 in 500 as recorded in the literature. There are also risks specific to the surgery. These include things that can happen around the time of surgery and also long-term problems. Around the time of the surgery, there is always the risk of bleeding. In fact, there is always some blood loss associated with this procedure. However, in over 90% of the patients, a blood transfusion is not necessary. Other things that can occur early after the operation include an infection. In the majority of cases, this is a wound infection that may require antibiotics or opening of the incision to release any pus and allow proper healing. The risk of an infection is less than 5%. The rectum sits right behind the prostate, and there is a risk of injuring the rectum during the procedure. This risk is extremely rare at less than 1%. However, it is for this reason that we give you a bowel prep. In this scenario, if you have a full bowel prep, fixing this problem is very easy and in general leads to no further complications. The long-term complications of having surgery obviously include urinary leakage, otherwise known as urinary incontinence, and erectile dysfunction. After the catheter is initially removed, most patients experience some loss of urine. I do recommend that you bring a diaper or a safety pad to wear immediately after the catheter is removed. In general, urinary control returns fairly rapidly in the majority of patients, such that at 6 weeks out after the surgery, about 2/3 of patients are relatively dry, wearing maybe one pad or no pad at all. The remainder of patients may take up to 1 year to get better control back. However, even at 1 year, there is about 5 to 8% of patients that continue to have bothersome leakage, requiring 2 or more pads per day. There is also about 1% of patients who have terrible leakage and require diapers. For these patients who are bothered, there are other procedures such as the artificial urinary sphincter or a sling to help support the muscle of control to help with this problem. However, I should caution you that urinary control will never be exactly the same as it is now. Even patients who are not leaking may still report that occasionally a drop or two escape, if they pass wind or cough really heavily without guarding, for example. After the procedure, I recommend that all patients start Kegel exercises to help them with the recovery of their urinary control. Recovery of erectile function is the second issue. If we are able to spare both nerves to erection, recovery of erections can be expected in about 50% of men under 65. The better your erections are going into the surgery, the higher the likelihood you will be able to recover your erections after. However, if you are having problems with your erections now, even before the surgery, it is very unlikely that you will be able to have full recovery of your erections after. Recovery of erections occurs starting at about 3 to 6 months after the procedure. However, in some patients, it can take up to 2 and even 3 years after surgery to fully recover their erections. Again, 50% of men may never recover their erections. In order to help with the recovery of erections, I recommend that all patients after the procedure start using medications like Viagra, Cialis, or Levitra. In addition, twice weekly attempts at intercourse are recommended to help maintain blood flow to the penis. If this conservative approach is not successful, recovery of erections can be aided with other medications that may be injected directly into the penis or with surgery such as a penile prosthesis. Lastly, the connection between the bladder and the passageway can sometimes heal with some scar tissue. This is called the bladder neck contracture. It occurs in about 7% of patients. A possible sign of this problem is a decrease in the urinary flow after the catheter is removed. This problem can be resolved by doing a minor surgical procedure where a scope is passed through the passageway and the scar tissue is opened up. I think this summarizes the procedure and what we can expect in its recovery. I have not gone into the radiation treatments for prostate cancer, as you will discuss or have already discussed these with your radiation oncologists. If you have further questions, I will be happy to discuss them with you when I see you.